our Professor Abraham is already there. So probably we'll just go ahead and start the next session. And I think we'll have probably more time for discussion. So for the next session, we have three very eminent chairpersons. We have, okay, I think that's the wrong slide. Okay, so as chairpersons, we have Dr. Rizwan Ahamed, who is from Kochi and is a consultant at Rajagiri Hospital there. We have Dr. Ashok Dalal, who is an associate professor in the Department of Gastroenterology at GB Pant Institute of Postgraduate Medical Education and Research in Delhi. And we have Dr. Shubhra Mishra, who is a consultant at Asian Institute of Gastroenterology in Hyderabad. I request the chairpersons to start the proceedings for the first session. Over to you, chairpersons.
Thank you, sir. So the next topic is, am I audible?
Yes, yes, Dr. Rizwan.
The next topic is going to be very interesting. It's about the use of antibiotics for IBD and what is the current guidelines say about it. The speaker is Professor Bincy Abraham. She's a professor of clinical medicine, Houston Methodist Academic Institute and Weill Cornell Medical College at Houston. So looking forward to what she has to offer to enlighten us. Over to you, madam.
Thank you, Dr. Sharma. Thank you, Dr. Ahmed, and the entire organizing committee for having me. It's really an honor, and I'm truly humbled to be here with you, with all of you. So I would like to talk to you about antibiotics and inflammatory bowel disease. And I'll go through a few objectives here, really looking at the evidence that we have of efficacy in Crohn's disease, ulcerative colitis, and in Pauchitis. So the scientific basis of using antibiotics is really based on the fact that we know that luminal antigens can contribute to inflammation. There is a known dysbiosis in IBD patients. And so in theory, if you reduce the gut-derived bacterial toxins and its antigenic triggers, we could actually reduce a contributory inflammation. However, there are some cons in using antibiotics. We know that IBD is a chronic disease. Antibiotic use is needed likely long-term because we can't, completely fix this with acute treatment. And we know that there's maybe exposure to side effects of antibiotics, and it can impact the commensal bacteria and disrupt the microbiota and reduce overall diversity. And with that, we can potentially have a niche for growth of Clostridium difficile and fungal species. There could be resistance of MRSA and BRE, which we know is more common in IBD patients. And antibiotics may actually affect metabolism of bile acids, cholesterol, vitamins, and potentially contribute to certain changes or deficiencies. And we really don't have long-term data on the effects of microbiome of IBD patients with antibiotics. So knowing that background, let's talk specifically about the data that we have for Crohn's disease. So if you look at induction of remission data, overview of a systematic review and meta-analysis looked at 10 randomized controlled trials of over 1,000 patients. They found that because all of these studies were using different regimens of antibiotics and the prevalence of cold therapy with the antibiotics, there really was no generalizable conclusions for Crohn's disease for induction of remission. And the other part is most of these studies, the primary outcomes were limited to clinical indices, not endoscopic or other objective measures. So obviously, if you put a patient with Crohn's disease on antibiotics, if they have coexistent irritable bowel syndrome or small intestinal bacterial overgrowth, there may be improvements from those rather than reducing inflammation. So hard to generate the conclusions from that. Now, specifically, rifaximin has been studied. We're aware that rifaximin is a non-absorbable antibiotic without much systemic side effects. And we know that it affects the colonic microbiome and potentially increases beneficial bacteria such as Bifidobacter and Faecalibacterium prausnitzkii, which we know is better to have elevation of in IBD. And it may have anti-inflammatory effects by potentially blocking tumor necrosis factor on the intestinal epithelial cells. So that's a background theoretical potential for using rifaximin. In 2 randomized controlled trials, rifaximin was found to be effective in inducing remission in active Crohn's disease with a number need to treat of 9. Now, they, again, going back to wasn't objective measures, but remission rates of CDI less than 150 was significant. However, only if there was a baseline CRP elevation. At least we have some objective evidence these patients came in with active disease based on CRP. Now, a larger international randomized controlled trial used 800 milligrams twice daily, and that was most effective, not lower doses. Specifically for ciprofloxacin and metronidazole randomized controlled trials, Cipro compared to placebo, it was effective with a number need to treat of four patients. Ciprofloxacin, but in combination with budesonide and metronidazole, really no impact in overall active Crohn's disease. However, there may be some benefit in colonic disease compared to those with just small bowel disease. In combination of metronidazole with either clotrimazole or ciprofloxacin, there was no benefit. And metronidazole alone versus placebo, there was some reduction in CRP compared to the placebo. So potential for using these medications by itself. Now, on the other hand, metronidazole specifically had numerous side effects. We're aware of them by our patients complaining about nausea, dyspepsia, dysgeusia, anorexia, including neuropathy. So we know that we can't really use it long-term, and it may even limit its short-term tolerance as well. Other antibiotics, clarithromycin, clofazimine was studied, but no benefit in active Crohn's. Now, MAP, Mycobacterium avium paratuberculosis, we know there's a potential etiology for Crohn's disease, and that's a rationale for using anti-TB therapy. There were very few randomized controlled trials, but overall combined data suggested no benefit. Large trial of over 200 patients. It did improve remission rates at 16 weeks, but no sustained remission of 3 years, but no improvement in endoscopic scoring of Crohn's or the inflammatory markers such as sed rate or CRP. Now, how about maintenance of remission in Crohn's? There was a study looking at recent antibiotic prescription use, so really not a study of a clinical trial, but a data analysis of prescription use over 1,000 patients. They did find that if antibiotics were used, it reduced the risk of a Crohn's disease flare in the subsequent 2 months. So potential that it may reduce that, especially if a bacterial infection was triggering their flare potentially. Now, 3 randomized controlled trials of anti-MAP therapy compared to placebo did prevent relapse for up to 9 to 12 months with the number need to treat 4, but only during that induction time. Again, overall underlying, bottom line here, high rates of side effects and potential for antibiotic resistance can limit the antibiotic use, especially for maintenance of remission in a chronic disease such as Crohn's. How about perianal disease, especially for fistulae and abscesses? Well, there were uncontrolled trials with metronidazole use of 20 milligrams per kilogram showed that it can close 60 to 83% of fistulae, and combined metro and cipro improved symptoms 64% and closed fistula 21%. In randomized controlled trials, though, there were 3 that used antibiotics for 1 to 3 months in 125 Crohn's patients total with perianal fistulas. 2 trials of cipro versus placebo, or the metronidazole versus placebo showed no benefit, unfortunately, compared to the placebo arm. However, combining ciprofloxacin plus metronidazole was found to be beneficial over placebo with the number need to treat of 5. Now, keep in mind, though, that antibiotic use can reduce fistula drainage, but it doesn't necessarily always completely heal that fistula. And most often what happens is once the antibiotics are discontinued, the fistula recurs, it opens up and contributes to symptoms. Thus, antibiotics should be used in conjunction with other definitive Crohn's disease treatment, did not be recommended to be used alone. Prevention of post-op recurrence is another concern, especially for Crohn's patients. Well, there were several randomized controlled trials. The metronidazole 20 milligrams per kilogram per day for 3 months, or ornidazole use for 1 year, did successfully prevent clinical endoscopic recurrence with a number needed to treat of only 4. However, we could use it again long-term because of lots of the adverse events rates, and patients ended up withdrawing from the study. If they were able to remain on it, of course, we found successful outcomes. Now, rifaximin, actually much more tolerable, was given for 3 months and it reduced endoscopic recurrence, was versus 10% only compared to 40% of recurrence on placebo. Ciprofloxacin unfortunately did not meet the endpoints of the randomized trial, but there was a trend towards reduced post-op recurrence. Uncontrolled trial of anti-MAP therapy did not show benefit in preventing post-op prevention in Crohn's. So this is kind of a summary of the randomized controlled trials of Crohn's disease of using antibiotics for treatment. You see that for induction remission, rifaximin, ciprofloxacin, and maybe metronidazole could benefit. Maintenance remission, anti-MAP therapy. For perianal disease, combination of therapy, again, in conjunction with actual Crohn's therapy would be best. And prevention of post-op, metronidazole, ornidazole, or rifaximin was found to be beneficial. Moving on to ulcerative colitis. In induction or remission data, there was a meta-analysis of randomized controlled trials of over 5,000 patients. Again, we found higher overall remission rates with antibiotic use in active UC with a number needed to treat of about 7. In individual studies, ciprofloxacin or vancomycin, there was no efficacy. Oral administration was actually more favorable compared to IV administration. If you look at antibiotic combination, metronidazole with Tobra, or with amoxicillin tetracycline, or with Tobra, vancomycin, or rifaximin, given for 7 days to about 3 months, it showed benefit in moderate ulcerative colitis for inducing remission. 2 studies of combination of amoxicillin tetracycline and metronidazole in active UC, clinical response, remission, endoscopic remission were all enhanced up to 1 year. And rifaximin 400 milligrams, so a smaller dose, twice a day for moderate to severe UC patients refractory to steroids, did show improvement in stool frequency and endoscopic appearance and reduced rectal bleeding. Now, there was a concern using repeated courses of rifaximin, understanding that it's well tolerated and very low side effect profile. There was a concern that resistant bifidobacterium species could emerge, especially after a study showed 3 intermittent courses in ulcerative colitis patients showed this increased risk of this species. For maintenance of remission, unfortunately, there's only 1 randomized controlled trial. It was short-term for only 7 days to maintain remission in quiescent UC patients. However, rates were similar to placebo at 1 and 2 years. However, I really do not know what the efficacy of using the antibiotic very short-term for 1 week would be of benefit for a long-term disease. So unfortunately, we have very limited data on maintenance of remission and antibiotic use. So summary of randomized controlled trials of antibiotics in ulcerative colitis, specific combinations of metronidazole plus other antibiotics, use up to 3 months could be beneficial in induction of remission. However, no data for efficacy in maintenance of remission with antibiotic use because we have limited studies. Now, to conclude both the UC part here, there was the recent hot off the press study from our very own, and in this systematic review and meta-analysis, it confirmed what we have previously known as well. Using oral antibiotics in the setting of non-severe active UC could have benefit. And this was 13 trials looking at 785 patients, and they found it was beneficial in the setting of non-severe active UC, but using antibiotics, it was not beneficial in acute severe colitis, and we'll talk briefly about that as well. Now, acute severe UC, our American Gastroenterology Association guidelines suggest against using adjunctive antibiotics. This was based on meta-analysis of 4 randomized controlled trials comparing antibiotics versus no antibiotics or placebo. And they used different antibiotics, and the duration actually differed between 5 to 10 days. They found adding antibiotics to conventional severe UC therapy was not superior to no antibiotics, especially in decreasing short-term colectomy risk. Now, this study looked at the Indian population, again by our very own, using adjuvant combination of antibiotics in acute severe UC. It was a placebo-controlled randomized trial of 50 patients. And again, they found combined IV ceftriaxone and metronidazole did not improve outcomes. There was no improvement in CRP, partial Mayo scores, fecal calprotectin, or colectomy outcomes. So again, no benefit in using antibiotics in the acute severe UC patient population. Now moving on to Pauchitis. So again, the theory behind using antibiotics for treating Pauchitis, we know that bacterial overgrowth and fecal stasis can occur in the small intestinal pouch, and that can contribute to the development of inflammation there. Therefore, we treat our patients with antibiotics. It's been what we've been doing for quite some time. Now, what's the data behind it? Well, metronidazole was used 1 to 1.5 grams per day, found that it induces a rapid response in acute Pauchitis. A small randomized controlled trial, and Bo Shen has been our international expert on pouch diseases, showed that both ciprofloxacin 500 milligrams twice a day and metronidazole at 20 milligrams per kilogram per day for 2 weeks treated acute Pauchitis. And ciprofloxacin, though, was preferred over metronidazole because using cipro in general compared to metronidazole found greater reduction in total Pauchitis disease activity index scores, greater reduction in endoscopic scores, more symptomatic improvement, and better tolerability because of the lower side effects. How about chronic Pauchitis? There's been open label studies looking at rifaximin and 1,000 milligrams twice a day, ciprofloxacin twice a day for 14 days in combination. They used 18 patients who failed metronidazole or ciprofloxacin alone. They found the combination of adding rifaximin to the cipro, 55% had a clinical response and a third had clinical remission. Metronidazole, 800 milligrams to about 1 gram per day with ciprofloxacin for 28 days led to 82% of patients achieving remission with chronic Pauchitis. Rifaximin of 1,800 milligrams per day as maintenance therapy in the patient that had antibiotic-dependent Pauchitis. By 3 months, 65% were actually able to achieve remission. By 6 months, it was almost 80%. However, after that, the longer term use, the numbers started to go down. By a year, it was 58%. By 2 years, it was only 6%. In a small, those were all, again, open label studies, but in small crossover randomized control trial, we really have metronidazole, 400 milligrams, 3 times a day for 2 weeks compared to placebo. It did improve stool frequency, but there was no difference in inducing endoscopic or histological improvement. And over half of our patients reported adverse events, nausea, vomiting, abdominal discomfort, headache, skin rash, and of course, metallic taste that's known with metronidazole. So because there was limited data on pouch treatment, there was actually an international consensus that came up on treatment of Pauchitis. And included other, contributing factors of pouch disorders as well. And we made a consensus statement of what should be used. And I took out the antibiotic components of the consensus guidelines. So again, you see that they're not very high grades here. Most of them are grade C or D recommendation. And you can see the listed evidence here. For Pauchitis, primary prophylaxis for initial episodes of Pauchitis with antibiotics is not recommended, but first episodes of acute Pauchitis was treated with cipro or metronidazole. And for induction therapy for chronic pouchitis, a prolonged course of combined ciprofloxacin plus one of these 3 antibiotics can be used for treatment of pouchitis refractory to single antibiotics. Again, grade C recommendation, the evidence of before. Now for using oral vancomycin in C. diff-associated pouchitis, that was first-line therapy, which makes sense that we really should not be using metronidazole in our C. diff patients with inflammatory bowel disease, regardless of the location being in the colon or in the pouch. And so oral vancomycin is recommended for that. Pre-pouch ileitis can initially be treated with antibiotics. Again, evidence is very low, and it's a grade D recommendation. In pregnancy, treatment of pouchitis should be done with penicillin-based antibiotics, not quinolones or metromidazoles, especially in the first trimester, to reduce congenital abnormalities. How about Crohn's disease of the pouch? You can use antibiotics as adjunct induction therapy for inflammatory Crohn's of the pouch, but very limited data. Short-term and long-term antibiotics have been used for penetrating Crohn's disease, either with or without an abscess, but again, limited data. We made a consensus based on all of our clinical experience. Peri-pouch abscess should be treated with antibiotics and then with surgical or interventional radiological drainage. And long-term antibiotic therapy can be considered for patients with Crohn's disease of the pouch and perianal fistula abscess, but there's limited data there. So there's a lot of studies that really need to be done in this area. So in conclusion, for Crohn's disease, for induction remission, rifaximin, ciprofloxacin benefit. For maintenance of remission, antimicrobacterial therapies may reduce the risk of relapse. For perianal fistula, combined antibiotic therapy, metronidazole and ciprofloxacin can be beneficial, but use it in conjunction with Crohn's therapy, not alone, because if you use the antibiotic alone, it's a high risk of recurrence once you stop the antibiotic. Post-op Crohn's recurrence, short-term use of rifaximin or metromidazoles. In ulcerative colitis, active disease, combination of antibiotics and oral antibiotics led to the best results, but very limited data and maintenance of remission. And for pouchitis, antibiotics are effective in acute pouchitis, maybe less so in chronic refractory pouchitis. And antibiotic side effects and bacterial resistance really precludes the long-term use of using antibiotics in inflammatory bowel disease in general. Well, thank you.
Thank you, Dr. Bincy. That was a very nice presentation covering almost all aspects of IBD and antibiotics. It was very enlightening. Will you suggest some role of antibiotics in the setting of toxic megacolon when we are suspecting the patient?
Yes, so of course, I think everyone reaches out for the IV antibiotics in someone with acute severe UC, but unfortunately, we do not have any evidence, and you saw based on the studies, an acute severe UC guidelines, both also in the Indian population as well, that there was no increased benefit. It did not prevent colectomy. So again, having a patient with acute severe UC and toxic megacolon is even a smaller group, but subset of patients that we have. So as you can see, there would be limited data on that. In my opinion, someone with toxic megacolon, really there's no, I mean, there is a role that if they have a toxic megacolon, they could have these micro perforations, that they could have a general overlying infection from that before they perforate. However, these patients will need to be going emergently to the operating room anyway, regardless. And at the time of the surgery, the colorectal surgeons can let you know what's really going on in that abdomen. If they were successfully able to take that colon out without seeing any perforations, then the patient's much better off. However, often what happens with toxic megacolon is that these patients end up having perforations, even if it's micro perforations, and they need antibiotics, during the time of the operation itself, not necessarily as a treatment for their ulcerative colitis. It's more of a treatment of aftermath of their disease course.
Yeah, agree, ma'am. But there is one small subset which refuses surgery, or sometimes the patient is not a surgical candidate. There we can use that. Thank you. Any other questions in the chat? I don't see any other questions regarding this. Thank you, ma'am.
There's There's actually a question regarding CMV infection in patients with acute severe ulcerative colitis. That do you stop steroids when it's confirmed that it's CMV colitis, or do you continue that? And which drug do you prefer for CMV colitis?
Yes, so for CMV colitis and severe UC, my plan of care is if the patient is not improving after about 48 hours of 24 to 72 is kind of like the cutoff, but you make our clinical judgment based on how the patient does. So about 48 hours if the patient is not responding to IV steroids, I tell all my GI fellows, okay, these patients need to get a Flexig to rule out CMV. And if we do find CMV, they find the classic punched out ulcers. And the CMV is found, and we actually have our pathologists expedite the evaluation because sometimes the staining can take several days. And so we talk to the pathologist, expedite staining. But if we clinically suspect CMV before the pathologist even shows us that there is positive CMV, then I will go ahead and initiate therapy. I do go ahead and discontinue IV steroids, corticosteroids at the time, because first and foremost, it's an immunosuppressive. Secondly, it was actually providing no benefit to the patient in those 2 to 3 days anyway. So I don't see any further role in continuing the steroids. And I will go ahead and start them on IV antiviral therapy. I usually get infectious disease, of course, on board during this time. And to determine, first and foremost, starting IV ganciclovir, if they're starting to respond to antiviral therapy, then we may be able to salvage the colon and prevent a colectomy in these patients. If they do not respond, then they're being closely monitored by colorectal surgery as well. And we tell the patient, we know that with CMV colitis in the setting of acute severe UC, they have a much higher risk of colectomy. So the patient needs to be aware as well of the potential consequences if they don't respond to IV antiviral. In my career, I've only had one patient I was able to save in the acute setting of a CMV colitis and severe UC. I've had some other patients who were non-severe in that they were not hospitalized, but moderate to severe in an outpatient setting. I've had several I was able to save on antiviral therapy with CMV superimposed colitis. They actually ended up after initial IV therapy, and depending on the severity, some may require 6 to 8 weeks of IV therapy, but some were able to transition to oral valganciclovir, and several required six months of therapy actually, and then they were able to discontinue, but I make that decision in conjunction with the infectious disease physician.
Right, ma'am. So how do you decide to switch from IV to oral therapy? Because of IV therapy is impossible for patients to continue to stay in the hospital for so long. So how do you decide to switch from IV to oral?
Yes, so if they're staying in the hospital, I continue them on IV therapy, and then I work with the infectious disease to determine can they go ahead and switch over to oral vancomycin. And if so, then I'll have the infectious disease take over during that time. I'm still closely following them for the colon part as well. I could also take over, but I have the privilege of being able to work in a large medical center. So might as well use their expertise and not rely on myself as well. So if they're in the hospital, I keep them on IV. If they're able to come out of the hospital, then that's when I switch them over to oral, and then maintain them as long as they need to. And of course, in the meantime, I may be re-evaluating them by repeat colonoscopy, or I do bowel ultrasound in my clinic, so I may reassess their colon on intestinal ultrasound and make sure their colon wall is less thick than before, or you can always do imaging as well. But for point of care testing, I assess clinically and either endoscopically or by bowel ultrasound, and of course, laboratory markers as well. And if they're improving, it's working, and then you can go on to the next steps of other therapies if needed, or maintenance for their ulcerative colitis.
Right, ma'am. There's a similar question on C. difficile infection in acute severe ulcerative colitis. That do you treat it with only vancomycin, or do you use a combination of vancomycin and metronidazole? And
yes,
disease.
Yes, so C. difficile infection in acute severe UC. Typically, we start with vancomycin, you can use metronidazole in combination. The data, may show some additional benefit. However, it's not so great that I just stick with vancomycin alone. Patients are better able to tolerate vancomycin compared to the metronidazole. So that's my go-to. Now you can add rectal vancomycin as well. And so that combination can benefit. Sometimes I've used vancomycin plus rifaximin as well. So it doesn't hurt to do the combination. Adding the metronidazole, however, not a huge evidence behind it compared to using vancomycin or vancomycin plus rectal enemas. We do have fidaxomicin. I'm not sure if that's available there. So some patients who do not have or have been intolerant to vancomycin or had recurrence of C. difficile despite vancomycin, then we'll switch them over to fidaxomicin, which is a newer antibiotic. Of course, it's also more expensive for us too, but if you need to save someone's colon from C. diff, we got used to what we have to use.
Right. And ma'am, patients who have developed toxic megacolon with C. difficile infection, then do you go with a vancomycin enema or do you use a combination of oral and enema for those patients?
Yes, for toxic megacolon, I would avoid anything by enema to put any additional pressure. Now they need to go to the operating room, like no question, right? C. diff and toxic megacolon, bad outcomes if you continue to keep them in the hospital. Even if the patient ends up saying, forget it, I don't want to keep my colon. I mean, you need to let them know they could die from a perforation. So really, it becomes a moot point that colon needs to come out. So avoid anything rectally to increase any pressure that could inadvertently cause or actually cause a perforation, and the patients in the operating room much faster.
Right, ma'am, right. Okay, ma'am, another question about patients post-op for post-op recurrence of Crohn's disease. Do you recommend antibiotics only once the disease has recurred, or do you recommend them as a prophylactic therapy as well? That in the initial 3 months before azathioprine starts working, a bridge, antibiotic bridge for patients with Crohn's disease?
I'm sorry, you were breaking out a little bit. So,
right. So
can you repeat the question?
Like let's say supposedly there's a patient with stricturizing Crohn's disease who underwent angioplasty and resection. Then do you give an antibiotic as a prophylaxis to prevent recurrence or only as a treatment once it has occurred? Like how do you suggest we use it?
So after surgery, yes, I do use it as post-op prevention recurrence. It depends on how much the patient can tolerate the antibiotics, of course. I have educated all my colorectal surgeons to say, okay, any patient that's going for an operation like this, not a colectomy, of course, but in Crohn's resection, just like you mentioned, at least 1 month of metronidazole or type of imidazole they can tolerate at least for 1 month, or Cipro, or the combination if they can do combination. If they can't tolerate Cipro or metronidazole, then I typically would use rifaximin for 1 month. Our insurance is pretty tricky because we don't have that as an indication for post-op recurrence for rifaximin. So we have to treat it under an IBS diarrhea diagnosis, and it's for 2 weeks, then we have to renew it, and all of that. We have to do our little things that we have to get medications approved for our patients. But that's what I would do for minimum 1 month. Now, if you have a patient that has this is a stricture that's occurred after 10, 15, 20 years of disease, and you're not worried that they're going to have a recurrence anytime soon, they're a low risk post-op patient, then these patients may be able to maintain on antibiotics as long as they can tolerate it and not have to start a new, Crohn's therapy. On the other hand, if you have a high-risk post-op patient, maybe the young patient who after 1 year of diagnosis, developed a stricture despite medical therapy, then those patients, sure, I will start antibiotic, but I'm already starting to think about biologic therapy in this patient because the best data that we have is, anti-TNF therapy, and maybe some with the newer agents, but starting them on anti-TNF therapy soon after, like 2 weeks of, post-op clearance, and then start them right away. Often with us, we have issues with insurance coverage. You have to submit it to their insurance company. So sometimes that can take several weeks for the approval of the drug. So in the meantime, they're getting covered with the antibiotics to prevent that recurrence early, while we get the other medications approved and then started as they become an outpatient. So that's kind of our plan that we do.
Right, ma'am. Thank you so much, ma'am. I think we have exceeded the time which was given to us. Thank you for it. Was a thank you.
Thank you for having me.
Thanks a lot.
Yes, ma'am.